This week on the BackTable podcast.
So my background prior to medical school, I worked as a technologist in interventional radiology. And I say that to say that at that time, a TIPS was like a 4 to 6 hour procedure, guaranteed it was going to be. And then things moved along, and in residency and fellowship at UVA, a TIPS was probably like a 2-hour procedure, most likely, somewhere around 1 hour, as we started to introduce ICE and use it some there. But now, like with all of these technologies, and specifically with Scorpion and what you're able to do with it, to be able to steer with ICE, it's pretty much less than an hour procedure, unless you run into some unforeseen thing or have extra work to do, like a lot of embolization. So it's just interesting to think back on my 2 careers and how that's changed over time as technology has evolved with the procedure.
Ladies and gentlemen, welcome to the BackTable podcast. You can find all previous episodes of the podcast on iTunes, Spotify, or our website, which is backtable.com. Very easy to remember. Subscribe to the show, leave us a review, or reach out to us on social media. Now, a quick word from our sponsor. For over 50 years, Argon Medical has been a dedicated partner in providing interventional solutions that empower physicians to deliver exceptional patient outcomes. Argon is a U.S. manufacturer and an innovator that partners with healthcare providers globally to offer vascular and oncology solutions, like the Scorpion Portal Vein Access Series, which utilizes a patented curve-in-curve system to offer physicians 360-degree range of motion for procedure accuracy and versatility. Argon relentlessly pursues better in all that they do, as demonstrated by the recent product launches of the Kodiak dual-port coaxial introducer kit and the SuperCore Advantage semi-automatic biopsy instruments. Learn more about these products and Argon Medical's mission to improve the lives of patients and caregivers at argonmedical.com. And now back to the show. Our topic today is a favorite of BackTables, and I think a favorite of interventional radiologists in general. We're talking TIPS. Our focus today is going to be talking about using or potentially not using ICE. To help us with this discussion, we have 2 interventional radiologists, Dr. Dylan Suttle and Dr. Chengazi. Guys, welcome to the show. We've covered this topic a few times on the show, and we will link to those old episodes, specifically our 4-part series with Dr. Linsky. I think it's episode 131 through 135 or something around there. We'll link to it. But today we're going to be focused on using ICE. Guys, welcome to the show, and thanks for coming on.
Hey, thanks so much for having me.
Thanks for having me.
All right, let's just get this out of the way. What do you guys' practice look like right now? Horace has been on the show before, so we'll start with Dylan. Dylan, so just tell me about your practice and also like your portal hypertension practice.
Yeah, sure. So I'm in a large private group. We have over 90 radiologists total. There are 11 interventional radiologists. We have a large, ever-growing stable of APPs that help us boots on the ground. We cover about 5 core hospitals and then a few other outlying hospitals in and around Greensboro, North Carolina. As far as portal hypertension goes, we actually have, we want to talk about this a little bit later, but we actually have a portal hypertension clinic that we've created here. Yeah, we can talk a little bit more about that, but we do about close to 60 TIPS a year now among our facilities combined.
Okay. Are y'all affiliated with like a transplant center?
We're actually not. We're sandwiched between 2 geographically. So we actually have a lot of patients in our area who are in a lot of need that aren't captured within those areas. But I don't practice directly with or teamed up with any transplant surgeons or transplant hepatologists.
Actually, I might dig into that a little bit more afterwards. All right, Horace, tell us about your practice and specifically about the portal hypertension part of the practice.
Yeah, so also in a private practice group with 5 IRs. We cover a children's hospital and then 3 other hospitals. One's a level trauma center and then 2 other tertiary centers. And then we have our outpatient clinic, which has been growing, very rapidly, especially in the last, year and a half, 2 years. Portal hypertension wise, in the level 1 trauma center serves a very sort of underrepresented community in the city of Buffalo. And so we end up seeing a lot of advanced cirrhotics, and we have a very close relationship with the hepatologist there. We don't, as of yet, have a dedicated portal hypertension clinic, but want to grow in that direction. There's no transplant center or liver transplant center in Buffalo, so we do work with Rochester up the street. I trained over there, so I know a lot of those surgeons, and they have a transplant hepatologist that kind of comes out this way to run a clinic as well. And then, we do have patients that go to Cleveland as well, because we're kind of, again, sandwiched between 2 big programs. But There's just a massive underserved population here, and there we see a lot of cirrhosis. There's a decent number of emergent tips, and then I think elective tips, we're probably seeing anywhere from 25 to 40 a year, depending on the year.
So like ballpark total, how many tips per year? I mean, I'm not going to hold you to it.
Yeah, I mean, they're probably in the range of like 50. It had actually downturned quite a bit like a couple of years ago, I think because of a lot of different factors. But in that time, we actually bolstered our relationship with the transplant centers. I think a lot of patients were kind of being shipped uptown, and then we were finding patients that were kind of just languishing, getting recurrent paracentesis. And that's part of the reason why I want to build up the portal hypertension clinic, because in the absence of a surgical ICU that's really equipped to deal with these really sick cirrhotics and hepatologists that really understand, decompensated cirrhosis very well or its management. These are some of the sickest patients that you could see in a hospital. And I think a lot of times, even the referring providers, et cetera, err on the side of get this patient to another center that is more equipped to deal with these things when they get advanced. And so I think that's one of the real values of an interventional radiologist in this practice, is because we deal with these patients at their most decompensated and severe. And we understand the decision-making behind TIPS, BRTO, and all these other procedures that people often forget about, and then considerations for transplant surgery and the subsequent follow-up. We can add a lot of value there.
Dylan, can you talk a little bit about your group's portal hypertension clinic and like some specific questions that I'm kind of interested in? How long have you guys had it running? What kind of patients do you see? And I guess like when you guys started it, you must have had something in mind. Like what did you see was the value in putting that like very specific clinic in place?
Yeah, to give you a background, I had a patient who I had done multiple paracentesis on in an outlying facility where we don't have any APPs at practice, to the point that I basically knew the guy. And if you open his imaging jacket, it's just para, and you scroll down, and that's all he's had twice a week for almost a year. This is no way to live. So I talked to him, and he said that all of his doctors had said he's not a candidate for the TIPS procedure. So I dug into his chart a little bit more, looked through things. His MELD was like 11. There were no red flags or absolute contraindications. So I reached out to this PA that was seeing him out of town and said, hey, can I please see him in my clinic? Like, I think this would really help him. I did. He dried up in a month. And then, it's been 2.5, 3 years since his TIPS, and he's doing well. So that was kind of a motivation for me. Like, how many other patients like that are out there that we're seeing? So we actually have a stronghold on all the fluids in our area and do most of them. So the idea for our clinic was twofold. On the front end, to recruit patients who may benefit from a TIPS or other portal hypertension intervention. And then on the back end, to prevent them from bouncing back right after their TIPS. So on the front end, what we did was basically any patient that gets 2 paracentesis in a month, their chart is sent to me directly. And we've been doing this for a little bit over a year now. So my inbox fills up, and sometimes I'm begrudgingly like, oh man, I need to look at all these patients. But it's been a great way to grow our practice. It's been a great way for me to learn tons, because I kind of pour through their chart. I look at, we have a standardized template that I built that's basically who their gastroenterologist is. How long have they had cirrhosis? It's decompensated or not? What other past medical history do they have? Have they been seen for transplant before? All the things that you would normally ask. I usually do some screenshots of imaging, and then I kind of leave it up to the gastroenterologist taking care of that patient, saying, hey, we've reviewed them. They either are or they're not a candidate for intervention. If you would like us to see them in our clinic formally, we'd be happy to. And then that just kind of puts our flag in the chart of saying like, hey, we've reviewed this patient who we've otherwise taken care of for draining their abdomen. And this is kind of our stance on it. And then the second part of that is after the procedure. So after TIPS, as you guys have probably seen, patients bounce back for hepatic encephalopathy all the time. Even if, they look good, they go home, they don't get their lactulose or just simply don't take it. So the way that we've tackled this is simply calling the patients. So after they go home from the hospital, we call them on day 2, day 7, at 2 weeks. And then usually we've seen them by a month, but if not, we call them at a month out as well. We've analyzed this a little bit now that we're a year out. About 90% of patients that we call do not come back to the hospital, readmitted for any reason. And then for those patients that have slipped through the cracks with our imperfect system, about 60% of those patients have actually been readmitted. So I think that's pretty telling that even just staying on top of these patients afterwards helps keep them out of the hospital. So the emphasis there is patient care, but also making the hospitals happy where we do these procedures, because that's such a big downside for them, is when we're bringing patients back less than a month out after discharge.
There's no doubt. It feels like the uphill battle whenever you're talking to hepatologists is they're highly concerned about encephalopathy, and rightfully so, but their viewpoint sometimes I think is a little bit narrow. So the fact that you guys are really on top of this speaks to the clinic you guys are developing.
To that point about encephalopathy, I kind of alluded to, like other procedures like BRTOs, et cetera. And I think that's one of the biggest things is how little many hepatologists know about that additional suite of interventions and what you can do. And oftentimes how amazed it can be is like, yes, this patient may have a history of encephalopathy, but they've got a 2-centimeter shunt that they've been living with for 2 years. And you can actually control the direction of flow and control the cross-sectional area of the tips and embolize that varix. So you have that twofold benefit of decreasing the risk of gastrointestinal hemorrhage and controlling encephalopathy while also making them much easier to maintain going forward. So there's a lot of that, I think, that doesn't go in, value of things like grand rounds to GI fellows, et cetera, can really help. And IR really improve their ability to provide that care.
That's been one big benefit of us reviewing the patient's chart as well, because no one's really looked at their ectopic varices or their shunts when their body CT is read. It's like, oh yeah, there's some varices, there's cirrhosis, the standard kind of stamp of what you see in a cirrhotic patient. So that's brought to light multiple patients who we've done interventions on who are otherwise told, oh, they have encephalopathy, they can't, undergo this procedure, but we've kind of been able to show those caveats and say, we could embolize this, make the tips, et cetera, and it would still be a safe procedure.
I think that speaks a lot to the focus of IR is that if we continue to put ourselves like very forward, like in the clinical picture, then we can kind of bring those nuances, like the discussion of like portal hypertension to like either gastroenterologists who it's not on their radar or just gastroenterologists who just don't have like a big portal hypertension practice. This may be like a smaller portion of their patient population. I mean, not all of these gastroenterologists are like hepatologists. I don't know if you guys run into that with like your GI guys are actually, this is just like a small segment of their patient book.
Yeah, a lot of it's a small segment, and it's also patients that it seems like they don't want to do much for lack of better words. So usually us saying, hey, I reviewed this patient, please let us help you take care of them. It's usually met with open arms.
There's a growing body of literature to support that as well, because I think historically also the attitude, especially from GI and hepatologists, was you think of the things that you're equipped to do, right? So they want to optimize the diuretics and they want to optimize the salt intake and the fluid intake and all those things and lactulose rifaximin. But the newer literature kind of suggests that getting to patients for earlier tips may actually improve their outcomes long-term as well, because you don't run into the diuretic-related nephrotoxicity, and you can tune the patient up for a procedure and do this high-risk procedure when they're relatively healthier and prevent them from also having worsening CKD or an interval gastrointestinal hemorrhage that makes it an emergent procedure. And so, again, I think it reinforces how valuable it can be to be involved with these patients' care early.
Agreed. All right, but I got to take us back on to topic because there's so much to talk about with tips. So I know that just to Dylan and Horace, we're going to skip over a lot of stuff, but it's not because we haven't covered it before. So if you guys feel like compelled, be like, we can't really say that until we talk about, whatever. I'll oblige you guys. You guys are gracious enough to do the show. But first, I just wanted to jump into ICE. And so if you could, Horace, just tell us what ICE is. And then from both of you, I want you to answer the question is, please be as specific as possible in talking about what probe you use and what ultrasound setup you have, or any details that will help someone who's just never used it. Be like, they can say, look, at least Dr. Suttle said this was a reasonable place to start. Maybe it's not the ideal ICE probe, but anyway, just be as specific as possible if you know it.
Yeah, so ICE is, I think traditionally it's intracardiac echo, but basically it's a side-firing intravascular ultrasound that usually has a 90-degree field of view, and you can place it, inside the IVC and look kind of right laterally at the liver. And I don't know what manufacturer our probe is, but typically my setup, if I am using ICE, is to, have the IVIS machine or the ICE machine kind of towards the feet. And then I do a vampire stick in the jugular, most often because we don't have a suite of fellows or residents working with us. So it's usually a single operator procedure. I have done the cases if you have the luxury of a second operator or a good technologist or somebody else to hold it, it could be beneficial to kind of come from the groin and use it that way. But then you have to do some mental math in terms of which way you're turning things, et cetera. So I think that's the gist of what ICE is.
I don't know if I could beat. Horace nailed it. He nailed that concept. So we use the 8 French AccuNav ICE catheter. Some of these are Siemens brand, and then others are the refurbished Stryker brand, just depending on which hospital I'm at and kind of the flavor of the day. I can't tell a real difference once I get going in the procedure. So With both of these, I go femoral for my procedures. The first ice case I did out of training, we went vampire stick. One of my partners was involved and kind of asked me for some help because he had heard I used it. And it was just way too crowded for me up at the neck. And I remember our catheter kept flipping over onto the ice probe, trying to select the hepatic. And I trained by going femoral. So that's how we go femoral now. And I don't have fellows or residents either. I do have the luxury that a lot of times I have one of my partners at the facility where we do most of our ice tips. And that's kind of the key part of the case. So sometimes they'll bounce in and help steer. But I found that a lot of our technologists really enjoy me taking the time to teach them exactly how to use it and what I'm looking at and where. And then it's simply a matter of saying, okay, go clockwise, go counterclockwise a little bit more. Okay, that's what we're looking at. And a lot of them really take a lot of pride in driving, getting it set up, and then allowing us to like get that first stick. And they're like, yeah, I helped do that, which I like encouraging that, but it also, helps grow their skills as technologists as well.
All right, hold on. There are a couple of things that I do want to dig into. So Harsh, you said it's a 90-degree like field of view. So this is the same field of view that you're used to seeing on like a transabdominal probe.
Yes and no. I think, if you think of a transabdominal probe, it's a long surface, right? And so the image looks very different. But yeah, it is typically very similar to what you're seeing there, but it's just kind of coming from a point source, almost like one of those. It's not as nice an image as a transabdominal probe because you have a much smaller array, and the penetration isn't as good.
I guess I meant to say that it's not like you're looking like an intravascular ultrasound where like, looking at IVUS and looking at ice, I think are two different things. Like it can be disorienting if you've never seen like an IVUS before, but like that's not really what you're seeing. Like I guess I wanted to break down that barrier for like the audience. Have you even never seen an ice probe?
Yeah, so
it's not all that dissimilar.
For an IVUS, where you're getting a 360-degree image along the periphery of the catheter, you're kind of inside the lumen and looking around. Ice is very different because your image is going to be the same superficial to deep, or in this case, I guess, deep to superficial image that you're getting with the probe, where it's whatever's closest to the probe to whatever's furthest from the probe in a 90-degree kind of spread. Yeah.
There's one other thing I wanted to deconstruct or just put a finer point on for the audience. Dylan, will you just clarify what a vampire stick is?
Yeah, so vampire stick is essentially when you have two sticks next to each other into the jugular vein on the neck, a la Dracula. So the alternative to that would be a single stick in the jugular just to get your sheath and your stent down and deployed, where you take ice up from the femoral vein from below and kind of park it in the perihepatic inferior vena cava.
One of the things pre-procedurally that I did want you guys to touch upon is if you had your druthers, what do you prefer for cross-sectional imaging? And then when you are looking at the imaging, like kind of take us through a little bit of like what your thought process is as far as procedure planning, like specific to procedure planning. Dylan, let's just start with you.
Yeah, if I have my druthers, we have a nice protocol for a multiphasic CT of the abdomen and pelvis where we get a really nice portal venous phase. So I like to look at that. I find that kind of buzzing through in the axials gives me a lay of the land, but the key for me is looking at the coronals or the sagittals. And when I'm kind of planning where I want my needle to pass or which veins I would like to connect, typically for me, either on the coronal or the sagittal, if I can see the nice hepatic vein close to or in the same plane as my portal vein target, that gives me a lot of confidence going into the case that it's going to be a pretty straightforward, quick, easy throw with ice guidance.
Yeah, so anatomy with the CT. So we typically, unless, in an AFP negative patient that's not concerned for like HCC or anything like that, we typically just do a single portal venous phase. I think, with our protocol, we get a decent look at the hepatic veins, although they're harder to see than the portal veins. Rather than like a traditional coronal or axial reconstruction, my go-to technique is actually to look at the scout image, and I'll put scout lines on the scout image and then scroll through the axial. And I'll kind of go to, hey, this is where my hepatic vein is, and I put my scout line there, and I take note of the rib position to diaphragm and distance from the, the right lateral margin of the spine, and kind of make a mental note of that. And then I'll scroll down to the portal vein, so that when I have the patient on the table, I'm really just kind of looking at the same landmarks. Okay, I was about, halfway down the rib, about this far over from the spine, and I need to go about 1 rib space or 1.5 rib space medially or whatever it is. And that kind of gives me a kind of simple way of looking at the anatomy on the CT. The anatomy always distorts a little bit when you get that stiff cannula in, or if there's a large amount of ascites and as you drain things. But I feel like as a relative sort of, I'm going about this many rib spaces and this far away, it gets me in the ballpark pretty reliably.
One of the things I want to talk about specifically with ICE, is there anything that you guys see on CT or any other kind of imaging that you're like, well, this patient is not going to be a great candidate for ICE? Like one of the things I was just thinking about is like patients with like very, very fatty livers where maybe the probe just doesn't transduce as well. Maybe that's not the right word. I'm not a great sonographer person, but you just can't see through. It just doesn't penetrate as well.
Yeah, I've never had really any issues with the echogenicity of the parenchyma itself limiting what we're able to do. The thing that I look for, if you have no veins that are on the same plane on the coronal or sagittal, you really get into this area of, okay, I'm going to have to be moving my ICE probe from when I exit the hepatic vein to entering the portal vein, and it's going to be more challenging. The one thing that I have seen and run into a few times is patients with accessory right hepatic veins that are really down low. Their right portal vein is usually very far posterior and it's horizontal. So that's kind of a red flag for me. If they have an accessory hepatic vein, then that's one of the things kind of in my search pattern that I look for to say, is this going to be challenging or not? If they don't, and you can see veins on the same plane, then it's usually pretty straightforward. But those are kind of some things that I say, this is going to be a really tough case. I don't not bring ICE to the table in those cases, but I just know that it's going to be much more challenging from a technical standpoint to connect the dots.
Is there anyone that you don't like ICE for that you're like, oh, it's just not worth it?
It's not worth it for me not to have it.
No. Okay. All right. I like that. All right. Harsh, you were saying that your practice is primarily doing tips without ICE. Is there any patient that you review pre-procedurally and you're like, oh, well, I'm really going to need ICE on this patient? Or like, so what determines if maybe you're going to bring that into the procedure is what I'm trying to drill at.
I guess one of the most practical things is, do I have a resident with me and what's their level of experience with it? Because I trained with ICE. I know how to use it. I feel like my experience with ICE has been, I definitely have had some livers where it was so steatotic that I just couldn't penetrate and couldn't understand the image very well. And I think I've had several patients. I mean, now knowing your strategy, Dylan, I may employ this. We're looking for the anatomy on the coronal and sagittal and finding a plane that might help sort of orient better. But I've had many patients where it's like, you're rotating back and forth. You're trying to figure out where are you, or the catheter wants to reflex. And depending on the knobs or the dials on it, like it doesn't really hold position well, or there's a lot of cardiac motion. I feel like for me, if I have nice wide open portal veins and I know the anatomy well based on my pre-look, then I don't think ICE necessarily saves me any time. Would it maybe potentially reduce the number of punctures I needed? Yes. But do I think it actually saves me time or adds significant risk? No. So I often don't use it. The caveat for that is if I do review an image and somebody's got very, very small portal veins or some degree of portal venous thrombus or partial occlusion in the system where I feel like it's going to be a tougher stick, a tougher venogram to interpret thereafter, then I may have ICE kind of in place, or at the very least a vampire stick in place from the get-go. So if I want to convert to ICE, then I'm good to go and I don't have to get a second access. The last thing that I'll add is I'm oftentimes a big proponent of just using extravascular ultrasound, so just a traditional transabdominal ultrasound. I find that if I can do a good pre-procedural mapping with that and I kind of know where I'm going and have that on background, I'm using it for my access anyway, so I'll keep it in the room. And sometimes I find that using that gives me the same information that an ICE would.
Okay. All right. So let's talk about it and try and keep this part brief because we're going to dig into different components of it. But Dylan, if you could, we just walk us through like your tips, like your case. And we don't have to get too far into like after you've actually made the stick, that's where we can kind of like tailor off pretty quickly because the stuff I'm going to drill down on is going to be the actual stick. But go ahead and just walk us through like access, set that you use, set that you prefer.
Yeah, so my basic setup, if the patient has ascites, I start draining them at the beginning of the procedure and kind of let that go as we go through the procedure. Then my next step is getting femoral access for my ICE probe. So my go-to, if they have a patent greater saphenous vein that's plump enough, I'll access that. I found that it achieves hemostasis a little bit quicker after the procedure. Additionally, patients that are under anesthesia, if they need to sit up immediately afterwards for respiratory issues, the anesthesia crew typically appreciates that. So I find that's a little bit easier. And some patients that are big, it's just more superficial and easier to get to. So Greater saphenous is my vein of choice from the groin. I put an 8-French sheath in and then take the ice probe up. The first thing I do before I even stick the neck is map out the hepatic vasculature with ice. Typically, I take it up until I start to see something beating. That's the heart. And then I look for liver, parenchyma. So my go-to is kind of rotating my probe to the posterior part of the liver. And then if you're looking toward the head, I then start rotating the probe clockwise. The right hepatic vein comes into view, and then I see what's typically the shared middle and left hepatic vein. So I map out the hepatic veins first, just kind of getting a lay of the land. And then typically within those windows of those hepatic veins, you can start to see portal targets pop up. So before the procedure, I kind of map out which hepatic vein I want to go into based on the distance between that and the portal vein to anticipate the pass that I'll be making through the parenchyma. And then I park the ice probe at the hepatic vein ostium and just kind of leave it there and have my tech or my partner kind of leave the probe looking right there. Then I get IJ access. The first thing I do after I get my 10-French sheath in is measure right atrial pressure. Just to have that right off the bat. As I'm going down, I just measure it. I typically use a Rosen wire and have that in the IVC as a safety. And then I use an MPA catheter with either saline, given that I'm using ice, or contrast, just depending on the case, on the back of the catheter. And I put that next to the Rosen wire through the sheath to use that to select the hepatic vein just by rotating the catheter and kind of puffing in. I've found that the hardest part of a TIPS case now can sometimes be getting into the hepatic vein. And that's one of the reasons I like ice for every case, is I am cheating by primarily using ice to find the hepatic vein, given that I know exactly where it is, instead of using 2D fluoro, standing on the pedal for 45 minutes and using, a whole vial of contrast, trying to puff and figure out exactly where you are. With a lot of confidence with ice, you can just steer right in and you see your catheter. And it's amazing the tiny little movements that you can make that will go from an unsuccessful hepatic vein access to successful that you can confirm with ice. You otherwise can't with x-ray. And who knows how many times you were there fluoroscopically without really knowing it. Then I take the back end of that Rosen wire that's hanging out of the sheath and I use it as a stiffener in my MPA catheter to get it deep into the hepatic vein. Then typically just advance my 10-French sheath over that. And then I'm parked in the hepatic vein and essentially ready to go. Now we're using the Scorpion access set. I really like it for many reasons that we can talk about, but I take that down and then with ice, essentially unsheath the Scorpion in a step down fashion where I have my 10-French sheath, the outer portion of the Scorpion and the inner portion of the Scorpion, a coaxial setup. So my needle is exposed. And at that point, I give up fluoro for a minute and I go directly to ice. So ice at that point is positioned where I have my hepatic vein and portal vein target all in the same plane. And then I simply just drag that coaxial setup back until I see my needle tip. At that point, I start messing with the outer part of the Scorpion and I steer that toward my portal target. When we first started using the Scorpion and ice, I tried to overanalyze this and was like, okay, this is going to be anterior, this is going to be posterior, left and right. Your ice screen is upside down and it's just a total, it's really hard to wrap your mind around those directions. So I've simplified it, which is just, I turn it this way. And if that's wrong, then I turn it the other way and kind of in my mind on the ice screen, that's the way I go. So point the outer portion of the Scorpion, which if you haven't seen it, there's an outer stylet essentially with a catheter and an inner needle with a catheter over that. And those kind of are curved at the end and rotate independently from each other. I get the base catheter, turn it toward the portal vein, and then start puncturing with the inner catheter and watch that on ice until I get to the portal target. Typically, it's different. When I was trained with Rashi Shitas, it was like these violent punches of just getting it through, punching through that stiff parenchyma. But with the Scorpion, you're able to just kind of slowly but surely steer that inner needle in the right direction until you get right on the wall, the portal target, and then just pop it in. In my opinion, it's much more elegant and a very controlled, safe procedure.
All right, you heard it here. Dylan described the portal venous puncture as elegant. All right, Horace, you can talk about yours from the get-go, but also highlight a little bit of how yours is different. And,
mine's very different.
But just take us through
I love it because mine's very different because, Dylan, I was going to ask you Scorpion or Scorpion X?
Scorpion X.
Oh, okay. So it is like the Colapinto style needle with the hole, and you can pass the wire immediately. Okay. I was gonna say he mentioned Rosh Hashida and everything. It's like I'd never used Rosh Hashida. I was not a fan of it. I always used a Colapinto system, and I used Scorpion X for my access. But basically, get-go for me is, we talked about some of the factors on if I think I'm going to need ice or if it would be beneficial, then kind of get 2 accesses and then move the ultrasound off to the side. But most typically, I'm starting with jugular access, 10 French sheath in, and then I usually use, some sort of MPA catheter and a soft glide wire. And I'll just use that soft glide wire to watch how it's kind of deflecting in the hepatic vein and get down deep into the right hepatic. Where I trained, we always used to put a balloon catheter in and do a CO2 run. But I find that if I get a good wedge, that I'm able to just use a 10 cc of contrast, and I do a breath hold portal venogram, an indirect portal venogram that way. And that kind of helps me confirm the position of the portal vein with my, pre-op CT imaging. So I kind of have an idea of, okay, I'm in this vein and this is where I need to go. And then I use a super stiff Amplats to get, my 10 French sheath and the Scorpion X kit down. And then I essentially usually almost always start an anterior angle because I'm in the right hepatic vein based off of where I got to at the right inferior tip of the liver. And then I basically, push forward with the Scorpion X and then puff and retract. Yeah, so it's not as elegant as watching your needle entry with ice. I definitely do admit that. In the past year, I'd say the majority of my tips have been under an hour, oftentimes including an embolization. So I feel like there's something about having the Scorpion X, and we talk about the needle a little bit more. Dylan kind of alluded to it, but as opposed to your typical tips needle setups where you have a single curve and you're kind of pushing and angling wherever you are, I find that with the Scorpion X, if you're in the right hepatic vein and you're aiming anterior towards your portal, then that second needle gives you the ability to kind of rotate and kind of twist and find the portal vein pretty easily. So that's my technique in a very abbreviated sense.
Okay. So Dylan, one of the things I wanted to ask you about when you're using ice, and you touched upon it, that you can kind of inchworm your needle along, and then, you find like when your needle's just sitting right outside, it's almost like, like if you're going to access a vein or something, just with ultrasound guidance. But one thing I was thinking is a lot of times I guess when you're making your passes, I would just imagine that the liver shifts as you're, like, especially if you're pushing through a really fibrotic liver. So are you making tweaks the whole time to the ultrasound image to kind of like continue to follow that?
Yeah, you have to. So one thing I always tell folks is like, all right, now watch this as I introduce the Scorpion. And as you put that stiff set down, your ice image is going to change. And you just anticipate that. Typically, it doesn't change to the point that you can no longer see what you're doing. But then one thing I instruct whoever is driving the ice is just keep our portal target and the needle tip centered. Because as you do push, a lot of times you push that portal target kind of to the periphery of the image or even out of it. So just sliding that up and down as you go and tweaking it back and forth is certainly something that you have to do as you're pushing in. Typically, once you get that first kind of push and you're well seated in the parenchyma, if it's a longer throw, then it doesn't move too much after that in my observation. But yeah, after you kind of engage or you're trying to get out of the hepatic vein into the parenchyma, you can certainly see some movement, especially in the craniocaudal dimension.
Okay. So the other thing that I wanted to drill down on, because I've seen your video and a lot of the audience has, and although we will link to it, for audience members, we'll link to this video where Dylan does like a full tips, really well produced. I was commenting on it earlier, but you said like you hook your MPA catheter up to saline. I don't think that's going to make sense to anyone. Like why you would hook it up to saline, like when we're trying to select the hepatic vein, like what are you seeing there and what are you doing?
Yeah, so essentially if you puff saline, you can see the bubbles that are naturally within the fluid very well sonographically. To me, that's much more valuable than a vague kind of watered down contrast in the hepatic vein where you don't know exactly where you are. So with certain confidence, if I puff and I see my vein on ice light up with these little bubbles, I know that's where I am. I've essentially given up doing a hepatic venogram, which was like, beaten into us as one of the first steps you do in tips, because I know on ice, that's my middle hepatic vein, because this is right. If I go this way, this is left. If I go this way, that has to be middle. I know exactly where I am. With 3 dimensions with the ice, exactly where you are. So I've given that up. And one of the main impetuses for that was patients who have hepatorenal syndrome and are coming for their tips and their creatinine's 2.3. And you're really trying to do whatever you can to minimize the amount of contrast load during the procedure. So some tips now, essentially my only use of contrast is for my portal venogram that's pre-tips, and then my completion portal venogram, just to prove that it's there and for mapping purposes of the stent placement. But yeah, puffing with contrast under ultrasound is a way to definitively see exactly where you are.
So comparing like your technique to Dylan's, not that I'm trying to pit these things against each other.
Full disclosure, the way he's describing it, I got a tips coming up next week. I'm using Dylan's technique. I mean, it sounds a lot more elegant than
it sounds really sweet. Wait till you see the video. Wait till you see the video. It makes it sound...
I got to watch that video and I got to take some notes, I think. But what was your question?
So two things. How much trouble do you have selecting the right? And two, how often are you going right versus maybe a little bit less conventional middle hepatic for your tip set?
Yeah, so I haven't had historically too much trouble. I guess one thing I didn't mention in my technique is I don't start draining ascites right away. I typically leave the ascites in place because I find that especially the subdiaphragmatic ascites that you have in these large volume ascites patients, that helps sort of ease the angles out pretty significantly. So I oftentimes won't start draining the ascites until, at the very least, until my sheath is very deep in the right hepatic vein. But oftentimes, I won't start draining until I've got my portal vein stick. So once I've got a wire into the portal vein or splenic vein or down into the mesenteric, then I'll tell them to start draining it because I know it's still going to take me time to deploy my stent, plasty, embolize, etc., and then wake the patient up from anesthesia. So I find like I get the benefits of having the fluid in there for my angles, and I don't lose any time on the back end of it. Regarding selecting the hepatic, I think being able to see under ice is definitely like probably gold standard for making sure that you're in the right hepatic. One of the things that I kind of learned was if you're struggling a lot, change your catheter, change your wire, or do something different. Don't just try to fish around standing on the fluoro pedal thinking the same thing's going to work when it isn't. I teach, some of the residents and stuff that rotate through, like, it's so funny, like you struggle with something and then your attending comes in, they do something in 2 seconds. And it's like, well, oftentimes we're changing the tools around, we're flipping the script. And so I find like if you're really, really struggling with selecting the right, change something up and you'd be surprised. Sometimes using a C2 may work. Sometimes, changing to avert or a different hockey stick instead of an MPA may be beneficial. And that works for me. As far as going to the middle of the left, I guess without ice, I can't reliably tell you the answer to that question until the postoperative imaging, right? Because sometimes it's like, okay, I make an anterior pass and then I make a posterior pass, and the one that is and that's the one that makes it. And I'm like, oh, okay, well, I guess I just did a middle to right or a middle to left, right? So realistically, under fluoroscopy, I think this supports the use of ice in that case. Is you may not really know, and that may be why you struggle.
Fair. One of the things I just want to drill down for the audience who maybe wasn't picking up on the angles. When you're talking about will you just describe a little bit more, like when you're talking about like favorable angles with the subdiaphragmatic fluid, just kind of tell you what you're talking about.
So if you think, this is your vein coming down over here, and I want to get a catheter into the liver over here. When there's a lot of fluid underneath the diaphragm and the liver's down here, that angle is a gentle curve, or it's a gentler curve like this. When you drain ascites, oftentimes the liver will kind of suck up underneath the diaphragm, and it could be a much more acute angle, and that can make your catheter more likely to flip out, make it harder to get reliable access, can make it tougher to get the stiff cannulas and sheaths down, etc. So that's what I was alluding to.
Okay. That can sometimes be kind of like a fussy part of the procedure, just getting like your sheath down into the right hepatic, especially like when, like you said, or it's like you just have like an acute angle. I assume the same thing for you, Dylan, like even with ice, sometimes like an angle just doesn't want to work with you.
Yeah, totally. There's some where I'm like, okay, I'm gonna put an Amplatz wire down here and straighten things out from the get-go.
Yeah.
Other times, if it's straight down, I will introduce the scorpion through just my sheath, not even over a wire. But yeah, it's all about the acuteness of the angulation, and like you said, it can be the fussiest part of the case and sometimes the longest part.
So, Dylan, one thing that I want to hear about from you is you mentioned going middle hepatic, and even when you were in the pre-procedure workup stage, so like when you're looking at the coronals and sagittals and your cross-sectional, so you may know ahead of time, hey, middle is going to give me my best chance of success. So you don't necessarily feel compelled one way or the other to start with right or left. I mean, you just choose what has the best.
Yeah, I think you take the easiest throw. And in more cases now, using ice, going to be middle to left or a middle to right, just depending on the patient's anatomy. But I certainly use middle more now than I ever saw in training. I don't think that you have to be right to right. I think the patients still benefit the same way. It's all about just getting that gradient down. So yeah, whatever is there, I take what I can get.
Okay. One of the other things I wanted to ask you is, once you make your puncture, Dylan, is it then more like, okay, I'm in, puff, make sure that I'm in, or are you confident enough on ice where you can send the wire down and then see that wire go down? I'm not saying you're going to see it into the SMB or anything, but you probably can watch it go portal.
Yeah, I almost never puff once I'm in at this point. So one of the downfalls of the Scorpion is that there's so many moving parts. So every time you take a syringe off or move that little inner cannula, you risk it flipping or turning one direction and getting up against the wall of the portal vein that you've accessed, or even losing it. So once I think that I'm in, I essentially get a death grip on the thing, both components of it. And I ask the tech that I'm with to unscrew the syringe on the back and start. I use the glide wire advantage almost always to get into the portal vein. So I have them take the syringe off, whether it was either saline or contrast, depending on the patient, and just start putting the wire down. And then I usually take over once we're close to the end of the tip's needle, and then gently exit myself. And pretty reliably, looking on fluoro or even with ice, you can tell by imaging and feel if you're intravascular, which with ice, when you make the throw, by the time I'm saying, okay, let's put the wire down, I'm 95% certain that I'm in the vein at that point anyways. So there's a lot of, certainty going into it, but I rarely puff anymore just because I can see exactly where I am sonographically. So there's no great reason for me to waste even more fluoro and contrast on the patient.
It sounds like you can also bounce your position around by doing a step where you're hooking up another vial of contrast to do a puff, which you don't really need. So that's what I wanted to hear. Is your process any different? So you guys are using the same set. You're both using the Scorpion X, right? So is your process any different? You have access, you draw back. I'm assuming you're puffing, but then how does your wire advancement go? But just talk us
so
through, that whole,
typically, again, the part about the moving parts with the Scorpion set, I think, is the biggest aspect of the learning curve to it, because as opposed to normally you've got your Colapinto, your Roshishita, you angle it whichever way you want to go, you push, then you can kind of hold that angle with one hand and aspirate or clear the plug and aspirate as you retract, and everything's in one place. But with the Scorpion set, because you've got the outer portion, which is directional, and then the inner portion, which is directional, you've got to kind of have three hands. So I oftentimes utilize my tech to hold the outer cannula for me, and then I'll work with the inner cannula. So it's similar to a traditional tip set. So once I've angled which way I want to angle, then I have my tech, to standing kind of across from me to the right from the table. They put a hand on the access sheath, the 10 French sheath, and then the Scorpion handle, the outer portion handle. And then I'll make my pass with the inner portion, and I attach, usually a saline syringe and just clean the little plug. And then I use 2 cc's or 3 cc's of contrast on the back of the syringe, and I don't puff. I typically just aspirate and I pull back. And if I get a blood show, then I'll check with just a tap on fluoro and see, am I back in my access sheath or am I in something else? And if I have a good blood show, then I'll puff a little bit of contrast. And if I see, antegrade flow towards the liver or something that looks like a portal vein, then usually I'm using the same soft glide wire that I used initially for my access, and I'm passing that through my tips, through my needle, and just watching the way the wire behaves. If I'm confident that I'm into the portal vein at that point, then I'll basically try to feed as much of the wire as I can. I pull the needle out, and oftentimes I just pass a 4 French glide catheter, which fits through that inner portion. And that glide catheter, I find, passes through even the most fibrotic livers. It's very, very flexible, so it doesn't really kick anything back. And I'll get the tip of that catheter a little bit deeper than where my needle was, and I'll sacrifice the wire access and make sure that I'm in the portal vein. Oftentimes I find that, with my technique of going, I try to go right to right. I agree with Dylan's point that it doesn't really matter. You take what you can get. But when I try to go right to right, I oftentimes start a little bit more peripheral. And recently I've been finding that my sticks tend to be more peripheral. And when they are that way, the wire wants to go that way. So one of my favorite tricks is, once I've gotten that catheter in, I'll actually just pass a Benson wire. And it doesn't matter which way the Benson goes. If you push enough of it, it flips down the portal vein and it gets you in. And then I just follow that down and switch out for a stiff wire and move from there.
Just to drill down real quick on what Harris said, that's a really, really solid trick, using the Benson wire, right? I mean, it doesn't matter which way the Benson goes. You just let it go peripherally, but eventually it's got that floppy tip and it just finds a big fat version of the portal vein and just sails. So yeah, very nice. All right. So because you guys both use the same set, I think it's worth talking about like what's different about the set that you like and the learning curve associated with it. Dylan, I kind of want to start with you because I see using the Scorpion in conjunction with ice is like really, really powerful because like you have this like fine tuning and you can just be like inching it. But Horace, I'm interested to hear from you, like why you find like the small tweaks like very advantageous. Dylan, let's start with you.
Yeah, sure. So, it's like peanut butter and jelly, ice and Scorpion X. I feel like even though they're not really made for each other, and, I think that steerability under direct sonographic visualization is the main, that's its shining accolade, is that you can do that with it instead of just having a fixed curve on a needle. There's a couple other things that I like about it. One is instead of, this is where Horace and I differ as far as getting into the portal vein, instead of having to place another catheter and do another wire exchange, with a stiff enough wire, you can bully the tract of the parenchyma with the entire Scorpion system. And then when it comes time to put your marking pigtail catheter down or your predilation balloon, they all just sail through that predilated tract. And you're not up against that common frustration during a TIPS procedure where you're going down with a catheter and it's just bouncing off either the hepatic vein or the portal vein wall, and you're just trying to get down. You have to go with a small system. You can go to like an 0-8 wire and dilate up from there. So the ease to safely dilate the tract with the Scorpion itself is something that I think is unmatched with the other devices that are out there.
Dylan, I have to ask for a clarification. I haven't heard bullying. Is bullying the same thing as doddering, where you just, okay. So, but okay, explain it a little bit more, just like unpack it, just like one degree further for the audience who maybe has never, we have a lot of like trainees who do this.
Sure. So we always refer to the great Charles Dodder, as someone who essentially put a dilator over a wire to help do what now we typically do with angioplasty. So doddering the tract, or it was first described to me as bullying the tract, which kind of has stuck with me, is keeping that coaxial system of the Scorpion with your inner portion and your outer portion together. Once you have used the needle to enter the portal vein and your wire is well within the portal vein itself, keeping that system together and pinning the wire, you essentially just advance your tip's needle and the outer cannula that comes with it even farther into the main portal vein. It will twist, kind of like when you introduce your needle into the hepatic vein and you feel it kind of turn, and you just let it take that turn. Same way, but opposite direction this time. Just let it go down. I've only had 1 or 2 cases where it got to the point of resistance where I thought, I don't feel right about this, and I pulled it out and just continued with the case. But using it to get into the main portal vein and then just backing it out dilates the tract of the parenchyma just enough that you're not going to really alter your portal venous measurements, but you do have a wide enough tract that your tools then can be introduced into the portal vein easily without having to do multiple catheter exchanges with this tenuous access that you have to just make it big enough to get things like 5-French catheters down.
All right, Horace. How does your part of the procedure differ? Because at some point, you do have to float your pigtail or dilate the tract. Are you just not running into this problem, or do you have some problem, probably some troubleshooting mechanisms?
Yeah, so if I have that glide cath down, I got a really small profile system to do my portal venogram. So I'll typically just do a good portal venogram, either straight AP or with an oblique as well, to determine where my access is. If my access isn't into the main portal vein, it's close to the crotch or a little peripheral, and I'm happy with it, then I stiff wire down. And then to avoid some of the struggles that Dylan was sort of talking about, is I open an 8mm balloon. I know that I'm going to plasty my tips to 8mm, and I just plasty off the get-go. And usually I swallow the balloon with my 10 French sheath, and I get my 10 French sheath down that way.
8x80, I assume?
Yeah, usually.
Yeah. And so as the balloon's deflating, or maybe not as deflating, but like you're just like, as the balloon's up and then you're taking the balloon down, then you can just take your whole system over it.
Exactly. So I find that, the parenchymal tract oftentimes recoils quite a lot. It can be really tough in a really, really tough liver, but that's not every case. And most of the time I find that my struggle is at that portal venous access site. So I find that if I can get the balloon to de-waste there, an 8mm balloon is plenty big enough for a 10 French sheath, and that gets down. And then, if I'm using a marking pigtail catheter for measurements and stuff, that, if you float that through the sheath and position it wherever you want to be. Sometimes I'll even, if I'm unclear of where my exact access site was at the hepatic venous end, With portal venous stent, I'll get the sheath down, the pigtail down. I'll actually pull the sheath back, and sometimes before deploying or sizing my stent, I'll do a venogram where I puff a little bit through the sheath at the same time as I do the portal venous end, and that way I know exactly where my access sites are. I will say that in the cases that I have done with ice, and I'm sure we'll get there in dental and talk to you about it again, I think my favorite thing to do is pulling that uncovered portion of the tips back under ice so it opposes the wall of the portal vein, so you're perfectly positioning your stent. And that's one thing that you can kind of get with feel that I think is really elegant with the ice.
All right. So I'm assuming y'all's procedures are going to start to look pretty similar towards the end here. You both have like good steady wire access. You've dilated the track one way or the other. Can we talk about stent deployment and how that looks for both of y'all, and any tips that you may have for people who aren't doing mini tips, or maybe some trainees out there about either missed deployments or ways that you've gone wrong that now you're just thinking of in the front end and doing some things to keep you out of trouble? Dylan?
Yeah, sure. So I think that initial portal and hepatic combined venogram that Horace described is really essential. If you're not certain where your tools are entering the portal vein, I think it is good to do an oblique, usually an RAO, to kind of show exactly where you enter. I've seen some cases, I've been in some cases where you think you know where it is and you deploy your Viator, and then the Truth Machine CT later down the road shows you that you were like 2 centimeters off. And sometimes you get away with it. Sometimes it requires revision. But I think that's a good, important step, is to know exactly where you enter the portal vein with confidence, which you can't really size off of ice. I know that I've heard some people mention putting a marking pigtail catheter and seeing the radiopaque markers with ice. I've never had much success with that or been able to see them definitively. So yeah, once I measure how long I want my Viator stent to be, from the gold ring up to the hepatic vein confluence with the IVC. Then, as Horace mentioned, I use the 880 Athletis balloon. I find it tracks really well and it's super non-compliant, so you can just blast away. It doesn't rupture. Inflate the track, then take your sheath over that deep into the portal vein. I would say another key thing is to make sure that your 10 French sheath is deep. If you're flirting with, well, I think that my gold ring will land about there, then just go a few more centimeters if you're someone who's not doing tons of these, because kind of the common rookie mistake is, as you're putting your Viator in, the uncovered portion starts unfurling as you push it out of the end of your sheath. So you always want to keep that thing in the sheath and then unsheath it to expand the uncovered portion of the Viator. Then drag that whole system back. So know exactly where you enter the portal vein and get your sheath as deep as you can within it prior to deploying your stent.
So whenever you're pulling it back, are you looking under ice, or are you just same old fashioned way where as soon as you just like you uncover the 2 centimeters and then just pull back and you feel when you get resistance?
Yeah, I typically do it the old fashioned way. Sometimes if someone is still manning the ice, they'll be like, oh, look, there it is. It is cool to see. And sometimes you use that as a backup to confirm. But given the scrutiny that I give the entry point, I know fluoroscopically where that thing is, and I have to watch fluoroscopically to introduce it anyways. So I'm usually using that as well as feel, pulling back and be like, all right, I'm not going to pull any more than that. And that's a nice firm kind of bite of that gold ring up against the portal vein.
So for the trainees, there's a plastic sort of cover that comes on the Viator. Do not pull that off. Do not let your tech pull that off, because that will, deploy the uncovered portion and you wasted the stent. Okay. Another big tip is, I've got my sheath down, just like Dylan said. I put my sheath in deep. Oftentimes I'm at like the portosplenic confluence. You can always pull it back. You can't really advance without having to do additional steps. So I get in deep. There's a black line on that plastic piece that you're not supposed to pull off. Make sure you hub that plastic line all the way in. I've also made the mistake of not having that in all the way. And then the stent can open up a little bit inside that little, opens the vault of the check flow there. And then you wasted another Viator as well. Don't ask me how I know, right? And then the one other thing I'll say is, I have done cases where I've been doing like portal venous thrombectomy and stuff and using something like a 16 French sheath, etc. Deploy through a 10 French. You want to minimize how much that uncovered portion has room to open up inside the sheath, because otherwise if it opens up too much, it'll have some radial force on there and it doesn't want to track forward, and you could waste a Viator that way as well. So basically, get your 10 French in deep, hub that black line all the way in, push the stent in till it's well inside the sheath itself. You can pull that black plastic piece back. Then I'm basically going until my tips, the Viator is tip to tip with the end of the sheath in the main portal vein. pull back about 2 centimeters to uncover the uncovered portion. And you can see that ring really well. It's very radiopaque. And from there, you can pull the sheath and the stent back together. Now, it does look cool, like Dylan was saying, to wash that back. But one of the things that I found is I find for ice, you can really reliably see that ring. And especially if you don't do a lot of these, knowing that you've placed that ring right at basically your portal venous access is very helpful, because I've seen cases where, if your stent is too deep and you cover a branch of the portal vein, you can cause hepatic infarcts and stuff, depending on what the patient's underlying disease is. And if you pull that ring back too far into the parenchymal tract, everything looks good, but one of the causes of early restenosis in these tips is when you have uncovered, bile that can basically leak into the stent. So if you don't have a good feel of how far is too far or how hard is too hard, and you have ice in anyway, I do find that confirming your position with ice can be a big advantage and minimize the risk for tips revisions, etc.
Okay. So Dylan, we'll give it to you. And just in broad strokes, talk about the downsides of using ice. Like what the barriers, either true or perceived, are.
Chris, before we go there, just one more thing. We talked about the portal venous end of the Viator. Dylan, where do you like to land your proximal end? Are you like just into the hepatic vein? Do you extend to the IVC? And it's kind of a loaded question because I guess it depends on the type of transplants that they're doing at the centers for you guys down there. But could you speak to that a little bit?
Yeah, I like to get, in that 1 centimeter range from the hepatic to IVC confluence. That's typical, in that if I'm a little shy of the confluence, that's fine. If I'm beyond it, in some cases where you overestimate because you add a centimeter, then, I think that's okay. But that's usually where I'm aiming for.
And do you ever use ice on that end of things, before you deploy to see where is your stent relative to the IVC?
I don't typically confirm prior to deployment. I don't find that you lose too much length there. But radiographically, I usually have my landmarks at that point for my venogram and usually stick with that. Again, it's something that you can do, and you can use ice to its full potential to look, but it's not part of my typical practice.
Horace, no pun intended. Where do you land on that part?
Yeah, I think that 1 centimeter from the IVC confluence is right on the money. I think I like to err on the side of a little bit more superior than short. Again, when you're looking 2D fluoroscopically, depending on the AP sort of projection of the hepatic vein, you may think you're entirely inside the vein where, in reality, you're cross-sectionally or, across. And same thing as the portal venous end. If you leave uncovered liver, there's risk of that early restenosis. So you definitely don't want to go all the way into the right atrium. They need to take a cuff oftentimes to do transplants if the patient is going to be a future liver transplant candidate, and you don't want to leave it too short. So I've never seen anything bad happen from being near occlusive in the hepatic vein. The liver is fortunately pretty resilient in that way. So coming pretty close to the IVC confluence is my target.
All right. Dylan, so same question that I was thinking of beforehand, which was I wanted you to speak to the downsides of ice, whether these are true downsides or you think they're just perceived downsides of maybe operator inexperience. But I just want to hear I guess it would be the bear case for ice.
Sure. So I think there's two main things. One is availability and the other is the learning curve. So the availability of ice, depending on where you are, this was something that initially we had to borrow from our EP lab to do cases. And then we started doing it more frequently and they were like, hey, you guys get your own machine. So thankfully, to solve that problem, we were able to convert one of our ultrasound machines into a machine that we essentially just plug in our ice as we would any other linear or curved probe, which works well for our procedure because we use the same ultrasound machine for the para with the curved probe, for the linear probes for the vascular access, as well as the ice. And someone just toggles between those probes during the case. So that's really streamlined now, but we didn't start there. We started borrowing a machine that looked like a little 1990s black and white TV with antenna, kind of like really small, could barely tell what I was looking at. And now it's on our normal big screen ultrasound, very high resolution. So that was a challenge for us that we had to work through, just getting that available. But we're able to justify the expense of having the upgrade of the software on the ultrasound just because it's essentially something that we're doing almost once a week now in our department. In addition to that, the learning curve. So we are, I think, poised to be very good at using ice because we're used to, as you talked about at the beginning of this episode, using like a curved probe, but it's just inside the IVC. So some folks their left-right orientation on the screen or top-bottom is a little bit off from what they normally think. So I would just put it on however makes sense to you and use it that way. I think there is a learning curve for knowing the little tips and tricks of where to position it during the procedure, what to look for as far as mapping out the liver and things like that aren't exactly intuitive like just using ultrasound is. So I think kind of making a system of saying, okay, this is exactly where the hepatic veins are. These are my portal targets. Option A is this middle to left hepatic. Option B is going to be this right to right because it's smaller. And kind of having a game plan like that during the procedure helps. But there is a certain learning curve as far as not just seeing what's on the image, but how to use it.
Horace, what I wanted to hear from you, and I know that you're not using ICE as frequently, but what do you see the advantages of ICE being?
Yeah, so I think Dylan hit a lot of them. Being able to reliably know whether you're in the right or the middle and what that anatomy looks like is very beneficial. Being able to watch your needle entry into the portal vein and go straight to a wire advancement is also huge as well, because you're puffing, pulling back, minimizing contrast. Those are big advantages. And then I think that third point is being able to know that you're really perfectly deploying that uncovered portion of the stent entirely intravascular and not into hepatic parenchymal tract is another big advantage. It is helpful to have an extra set of hands for ICE, depending on what your tech availability is, etc. And then another downside is you may not have ICE everywhere that you go. And so I think although it's a nice luxury, and if you can electively do most of your cases that way, it's great. But you go to a new job and they don't have ICE and they don't have an EP lab or whatever, and you got to do a crashing tips, I think there is value to just knowing how to get in there and shove and interpret a venogram and size the stent appropriately as well. So I think there's still a role for that.
I wanted to bring something full circle. So like one of the advantages that I see to ICE, especially since both of you guys use the same tip set, is like those small like adjustments you can make to like the needle trajectory. Like how does that small adjustments help you if, I guess like, I mean, I feel like essentially like you have like infinite number of choices you can make with like how you want to direct the needle. Like how are you making the smaller adjustments? Like how are you making those work for you? How are you making those be efficient?
We didn't talk about this when we're talking about the technique, but I think that's a great point because, it makes me wonder how much of it is the needle system and how much is ICE, because one of the things that I find is, okay, if I know that I'm in the right based off of my venogram, I was able to get my catheter in a good position, I'm happy with it, etc. And I know that I need to aim anterior. I'd say that most of the time, if you're using a typical Gore set or Cook set or whatever with a big Colapinto needle, it's so dependent on how angled your needle was and how stiff the needle was and how much the needle straightened out when you were advancing. And so, you're taking a 20 cc syringe and adding a curve or whatever, and you pull it back and you find that, oh, my wire straightened out the needle or whatever else. There's so many variables to how that needle is going to behave inside the body. And I think the Scorpion kit really removes a lot of that because it's a very, very stiff outer cannula. You're angling it the same way that you would your normal needle. But then when you're making your passes aren't a straight shot or just that one curvature. You have your outer portion there, then you've got this other curved needle, and you can curve it this way and you can curve it this way. And when you're using those traditional sets, I think everybody's had this frustration where that you're getting right by the portal vein, right? You're really, really close. But to make another pass, you got to pull back all the way. You got to maintain all the same angles, and then you got to advance again. Whereas with the Scorpion set, you don't have to do that quite so much because you have the ability to partially pull back the needle and turn it a little bit, advance a little further. You can maintain your outer cannula position the same way and know that, okay, I'm just on the side of it over here. I'm going to aim just a little bit more medially. And so I think it gives you a lot more degrees of freedom in the way that you're manipulating the needle, which allows you to get into the portal vein easier with or without ICE.
Here, and I don't have any experience using the set, but the way that I've like conceptually see it, I don't want to call them mini passes, but you can make like a lot of smaller adjustments and kind of be probing around for the portal vein. If you kind of like you have a real sense that you're in the right direction, this is the right part of the hepatic vein to be in to make your passes. You can make smaller passes with that inner cannula, right?
It's a smaller needle and it's flexible. And so you can kind of walk around a clock face and basically be like, okay, I know that I'm in the ballpark. And if I'm 5 millimeters anterior or posterior, the needle's going to find it. I don't want to do too much marketing here, but it really is very good at finding the portal vein. And that's why it's kind of become my standard practice to go to the Scorpion X.
Well, I don't have any doubt that you guys are probably both pretty good operators and don't have much trouble finding the portal vein, but that's nice. All right. So can we talk real quick price with ICE? Dylan, can you speak anything about that or?
I think it's worth its weight in the sense of anesthesia time for me. So if I have a patient where I don't have to do a para and I don't have to balloon dilate after I deploy my Viator based on my pressures and I'm not embolizing anything, it's a 25-minute case. It's just putting the tips in and getting out. So, you compare that to, well, you can't use this. I don't know how much an $800 probe or whatever it costs. I'm not sure the cost, at our facility. But to me, that benefit of doing a safe single pass in a short amount of time, especially if you do have the patient that's crashing and burning, you get that up and you can see exactly what you're doing and make a single pass and be done with it, then, that's worth its weight in whatever you want to call it. But I think that I can't see an instance that cost would be prohibitive to the benefits that it provides, at least in our practice.
I felt compelled to bring it up. I feel like it's kind of a straw man. I'm glad you said 800. That's the number that I hear from time to time.
Plus the cost of the machine, right? So it's like, what, $50,000, $60,000 for the ultrasound machine if you don't have one that you can kind of upgrade. So I think it does depend on what the volume of the center that you have and if you have any other services that you could share it with. But I think most of the places that are kind of seeing tips with any sort of regularity probably could benefit from it.
Well put. Especially if you can do dual duty with your ultrasound machine, like use it for, all your ultrasound guided procedures and just have a couple different probes, a linear, a curved, and then an ICE probe.
Chris, since we are talking ICE, this is the question that I had for Dylan is, so much of ultrasound is like optimizing your image. Do you have any tricks or settings that you play with on the ICE to really get the right picture?
Yeah, besides the basic ones where you look at an ultrasound and you can't see anything in the far field and like a band, and you're like, oh, someone moved, the focal over there, like leaned on the machine and pushed it. Besides the obvious stuff, there's two main things every single case where we get going. The left and right to me is typically always flipped when I start on our machine. So I make sure that the left-right orientation matches. In my mind, when I'm moving the probe this way, it goes this way on the screen versus the opposite. And then our machine, which is a Siemens, I don't know the sonographic exactly the right terms to click on the physics part of our radiology boards here, but there's a button that says image and you click on it and then it says penetration and I click on penetration and the image just becomes so much clearer. So that's, the knobology is something that every ICE or ultrasound machine, you're going to have specific things. And we've had some help from our sonographers to say, hey, we're doing a procedure. You've probably never seen this type of ultrasound before, but using what will you help us kind of optimize the image? And that's been beneficial in some cases. But yeah, there's a penetration button that I highly recommend clicking if you haven't already, because then you can see a lot better.
That's actually very fun to me that you're like, yeah, if you can find the penetration button or the button that says image, like it typically gets better if you hit that button. Sorry, Horace, what were you going to say?
I was just going to say, it's interesting because our ICE machine is a separate machine altogether. And I've become very facile with our traditional abdominal machine. And I can play with, focus and harmonics and depth and all these things. I had no idea how to use our ICE machine. We kind of plug it in and, hopefully there's a rep around or, but to really be facile with it, I'm not there yet. And I think that's probably another one of those limitations. So it's kind of cool that you use the same machine that you use for other things as well, because I think that's another advantage for your setup.
All right, guys. So final thoughts. It doesn't have to be about ICE. It doesn't have to be about the set. If there's anything like you just want to leave our audience with, either about tips or interventional radiology in general, like it's open mic night. Horace, we'll start with you.
So we have an excellent tech who's now retired and he always used to jinx us, I guess, or you call it a jinx or not. But at the start of every tips was a pool, and every tech and every nurse and everybody in the room would kind of put their over under on how long the access or, we would typically do lidocaine to pressure. It's a fun way to make those cases inclusive of everybody involved, because everybody knows that tips can be a bear of a procedure. Although Dylan may have, removed a lot of that with his suggestions, and I'm definitely going to be using a lot of your tricks on my next tips, and I'll be sure to follow up.
Along those lines, so my background prior to medical school, I worked as a technologist in interventional radiology. So I did that for about 4 years, and I say that to say that at that time, a TIPS was like a 4 to 6 hour procedure. Guaranteed it was going to be. And then things moved along, and in residency and fellowship at UVA, the TIPS was probably like a 2 hour procedure, most likely somewhere around 1 hour, as we started to introduce ICE and use it some there. But now, like with all of these technologies, and I think specifically with Scorpion and what you're able to do with it, to be able to steer with ice, it's pretty much less than an hour procedure, unless you run into some, unforeseen thing or have extra work to do, like a lot of embolization. So it's just interesting to think back on my 2 careers and how that's changed over time as technology has evolved with the procedure.
I will say though, just to bring in a different point of view, is sometimes like I read like the SIR forum about, like I think recently there was a post about like tips with and without ice, and a lot of people have strong feelings about it, I guess is what I'll leave it with. And I don't know, sometimes I say like if it's not, if it's not broken for you, then don't fix it. Maybe it's just a layer of complexity that you want to deal with. But at the same time, like after talking with you guys and also, and we'll link to this audience, seeing Dylan's video feels pretty compelling. So I hope that at least, I'm not saying that every one of our audience members is going to go out and try ice. I mean, maybe there's some real barriers to getting it done, but I just hope the barrier isn't that it's too intimidating or it feels like too much of a hassle. Like I want to leave our audience like feeling like, hey, this is doable. If it's something you want to incorporate in your practice, like give it a go. What's the worst that can happen?
It makes me wonder, I mean, if you could really be that reliable, is the future of tips a hepatic hilar block and a single pass, and no GA at all? It's who knows? If you really, maybe we could look into that in the future. Let's see.
To our audience, thank you for listening. If you enjoyed the show but want more, check out the show notes of this episode. There's going to be show notes that are going to have a link to a video that Dylan put together with some of his colleagues. And then also, Horace, I got to get with you. You mentioned some literature on tips that I'd like to get those papers from you so we can put it and make it available for their audience. That wraps things up. We'll see you next time on the BackTable Podcast. Dylan, Horace, thank you.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at @_BackTable on Instagram, Twitter, or LinkedIn. BackTable is produced and hosted by myself, Aaron Fritz, and co-hosts
Chris Beck,
Sabine Dong,
Michael Barraza,
and Ali Behetti.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter,
Aaron Bowles,
Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Ann Dang,
Manisha Naganathanahali,
and Manbir Singh Sandhu.
Administrative support provided by Jamila Kennebrew.
Intro and extra music is Ripperoo by Skeptic Moon. Find us on Spotify or at local live music venues in New Orleans, Louisiana.
Thanks again for listening.